the beginning of the test, you will hear a beep sound. You have time to read the questions before you hear the extracts. You will hear each extract only once. You have to complete your answers as you listen. At the end of each test, you will be given 2 minutes to check answers. Part A. In this part of the test, you hear 2 different extracts. In each extract, a health professional is talking to his patient. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for Extract 1. Extract 1. Questions 1 to 12. You hear a doctor talking to a patient called Eugenius. For questions 1 to 12, complete the following notes with a word or short pause. You now have 30 seconds to look at the notes.
Hello, Doctor. Good morning.
Good morning. What's your problem?
Doctor, he is my son, Eugenius. A few hours ago, he fell off his bicycle. He was not wearing a helmet. He went unconscious for a few seconds. He complains of neck pain now.
Does he have any other illness?
No, Doctor.
Okay, what's his age?
12 years, Doctor.
Any previous injuries?
Very minor injuries, Doctor.
Was he taking any medicines?
No, Doctor.
Does he smoke or drink?
No, Doctor.
Can you tell me more about family history of illness?
Absolutely no illness in our family, Doctor.
Any weight loss or gain recently?
No, Doctor.
Well, his physical examination shows his blood pressure 150/75, pulse rate 80, respirations 18, temperature 37.4, saturation 97% on room air. He is moderately obese. His neck is symmetric, the trachea is in the midline, and there are no masses. No crepitus is palpated. The thyroid is palpable, not enlarged, smooth, moves with swallowing, and has no palpable masses. Normal respiratory effort. There is no intercostal retraction or action by the accessory muscles. Normal breath sounds bilaterally with no rhonchi, wheezing, or rubs. The point of maximal impulse is palpable at the 5 ICS in the MCL. No thrills on palpitation. S1 and S2 are easily audible. No audible S3, S4, murmur, click, or rub. Abdominal aorta is not palpable. No audible abdominal brutes. Femoral pulses are 3+ bilaterally without audible brutes. Extremities show no edema or varicosities. Gastrointestinal investigation shows no palpable tenderness or masses. Liver and spleen are percussed, but not palpable under the costal margins. No evidence for umbilical or groin hernia. No lymphatic nodes over 3 mm in the neck, axilla, or groins. Musculoskeletal test shows normal gait and station, symmetric muscle strength and normal tone without signs of atrophy or abnormal movements. There is a hematoma in the forehead and one in the occipital scalp, and there are abrasions in the upper extremities and abrasions on the knees. No induration or subcutaneous nodules to palpitation. I have reviewed his chest X-ray and it is normal, right hand X-ray, which is normal, and an MRI of the head, which is also normal. He has concussion, facial abrasion, scalp laceration, and knee abrasions. Admit him today and his health condition will be monitored by our team. We have observation team working 24 hours. Extract 2, questions 13 to 24. You hear a physician talking to a patient called Mr. Gregorius. For questions 13 to 24, complete the following notes with the word or short pause. You now have 30 seconds to look at the notes.
Hello, doctor.
Yes, come in. What's your problem?
Well, he is my husband, and he had a markedly abnormal stress test with severe chest pain after 5 minutes of exercise on the standard Bruce with horizontal ST depressions and moderate apical ischemia on stress imaging only.
What's his name?
He is Mr. Gregorius.
What is his age?
55, doctor.
Well, his cardiac catheterization today shows mild to moderate left main distal disease of 30%, moderate proximal left anterior descending coronary artery with a severe mid-left anterior descending coronary artery lesion of 99%, and a mid-left circumflex lesion of 80% with normal left ventricle function and some mild luminal irregularities in the right coronary artery with some moderate stenosis seen in the mid to distal right patent ductus arteriosus. He shows rest anginal symptoms, as well as nocturnal angina symptoms, and especially given the severity of the mid-left anterior descending lesion with a markedly abnormal stress test. I am prescribing him aspirin 325 milligrams once a day, Nexium 40 milligrams once a day, Zocor 40 milligrams once a day. Plavix 600 milligrams, which I am giving him tonight. I would suggest that you transfer him for percutaneous coronary intervention.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer, A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at question 25. You hear 2 doctors discussing the topic of keeping the immune system under control. Now read the question.
Doctor, could keeping our immune system under control be as easy as managing our diet?
Well, for instance, the immune cells involved in multiple sclerosis mainly depend on sugar to activate the disease. However, the common drug for multiple sclerosis, dimethyl fumarate, blocks this energy pathway. Contrarily, these energy pathways are feasible targets to treat certain diseases that might extend to dietary measures. I'd like to be extremely cautious about this because nowadays diseases and diets have become very common. However, the theory that energy metabolism is crucial in the way the immune system reacts suggests that there are possibilities that different kinds of diets are going to have impact on our immune system that we're just starting to understand but are yet to understand it completely. I wonder at some stage if the autoimmune diseases like multiple sclerosis may include diet as part of the disease management strategy, as well as other diseases where immune system and energy metabolism are essential, such as cancer.
Question 26. You hear physicians discussing the topic of coping with a peanut allergy. Now read the question.
Hello, doctor. What should parents do as peanuts have become an allergic substance nowadays?
It is really a very frightening factor to know that peanuts can cause allergic reactions, with increasing reports of sudden death in children following peanut ingestion, and new products are being launched on the market to help parents stave off a peanut allergy in their children. What I feel is feeding peanuts to children doesn't require any specialized products. Right now, we have the strongest evidence that kids are at high risk because they have a severe egg allergy or eczema, and the dietary guidelines suggest that infants with severe egg allergies or eczema should intake peanuts as early as their 6th month. What I feel is introducing peanuts to infants with moderate or mild eczema or egg allergies in a developmentally and culturally appropriate method would probably help prevent peanut allergies for the rest of their lifetime. Since peanut allergies are increasing rapidly, the early feeding strategy is something that the parents should consult with their pediatrician, as it is one of the best sources of protein.
Question 27. You hear the discussion between physicians on the importance of food challenge. Now read the question.
Hello, doctor. Why are food challenges necessary?
Following the recent death of a 3-year-old child that had a food challenge test, a new study of over 6,000 food challenges done found the safety profile very reassuring. Food challenge tests are the mainstay of food allergy diagnosis because other diagnosis procedures are not that precise. We have blood tests and skin tests for food allergies, which carry a lot of false positives. Therefore, in many instances, we do have to perform a food challenge test when the diagnosis becomes doubtful. There are a number of people walking around with diagnosis of food allergies who are actually not allergic to that food.
Question 28. You hear a discussion between doctors about fake Stop the Bleed kits. Now read the question.
Doctor, how do we get rid of the imitators of Stop the Bleed kits?
Stop the Bleed is a national campaign to increase awareness and provide training and kits to help the people witnessing traumatic bleeding. However, we must be very careful when obtaining the kit for our locality. The genuine kits are really very expensive, that may cost from $50 to $100 depending on the contents. However, there are some counterfeit tourniquets which are knockoff products. I would warn everyone that a tourniquet is meant for controlling acute arterial hemorrhage, will cost about $25 to $35. Therefore, if you're getting them for a lesser amount, you probably won't get the best one.
Question 29. You hear a physician explaining to his nurse about causes of obesity. Now read the question.
Doctor, could the bacteria in our guts impact the development of obesity?
We often see children eating the same diet and living in the same environment differ in their weight. I feel that there's an interaction between genes and the bacteria in our guts that may be the culprit. The findings suggest that it isn't just the components of the diet, but it's the interaction between the diet we eat, our genes, and our bacteria in our body. Every kind of different diet would cause obesity in an individual who is predisposed to becoming obese. Certain genes colonized with bacteria that are efficient enough to produce more nutrients for the individual, resulting in obesity.
Question 30. You hear a physician briefing staff about the herpes virus infection. Now read the question.
Typically, the herpes virus infect the genital or oral mucosa. They affect the mouth, causing cold sores or blisters that form on the mouth, lips, or gums. There may be a prodrome prior to the blister development with a burning, tingling, or itching sensation in the infected. Throughout the lifetime, the virus remains dormant in the nervous system, hence the cold sores which often reoccur in the same part. When it infects genital parts, it is called a sexually transmitted infection. The symptoms are similar to the oral infection of the virus. With the first outbreak, an individual may experience nonspecific flu-like symptoms like swollen lymph nodes, muscle aches, and a headache. There's also a possibility of having the infection without any signs or symptoms.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you will hear two different extracts. In each extract, you will hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now, look at Extract 1. Extract 1, questions 31 to 36. You hear the lecture given by a physician on the topic Amyotrophic Lateral Sclerosis disease. You have 90 seconds to read questions 31 to 36. Amyotrophic lateral sclerosis is a kind of motor neuron disease referring to a group of progressive neurological diseases that cause dysfunction in the nerves that control muscle movement, resulting in muscle weaknesses and changes our body functioning. The advanced stages of amyotrophic lateral sclerosis affects the nerves that control breathing, resulting in mortality. Amyotrophic lateral sclerosis is sometimes called Lou Gehrig's disease, after the famous baseball player who was diagnosed with this condition. Upper motor neuron symptoms include resistance to movement in the muscles and brisk reflexes and stiffness. Lower motor neuron symptoms include muscle atrophy, weakness, and twitching. The lifespan of the patients with amyotrophic lateral sclerosis is about 3 to 5 years after the appearance of the symptoms. Presently, there is no cure to amyotrophic lateral sclerosis, and treatment is aimed to relieve symptoms, to provide emotional and social support, and to slow down the progression of the disease. Amyotrophic lateral sclerosis attacks the nerve cells used in voluntary muscle actions called motor neurons. Motor neurons are found in the spinal cord and in the brain. As amyotrophic lateral sclerosis progresses, motor neuron cells degenerate and die. Therefore, they stop sending messages to muscles for performing actions. At this stage, the brain can no longer control voluntary movement, and the muscles gradually weaken and waste away. As amyotrophic lateral sclerosis progresses, it affects all the voluntary muscles where the patient can no longer control their face, arms, and legs. At this stage, inability to breathe results in respiratory failure. 50% of the patients with amyotrophic lateral sclerosis will live for 3 years or more after the diagnosis. However, some patients live for longer. About 20% of patients will live 5 years or more after diagnosis, while just 10% of the patients will live for 10 years or more, and 5% of patients will live for 20 years. There are different types of amyotrophic lateral sclerosis, classified based on their signs and symptoms and with a genetic association. Amyotrophic lateral sclerosis can be sporadic or familial. Sporadic amyotrophic lateral sclerosis occurs randomly, and it accounts for 90 to 95% of patients. There is no clear risk factor or cause. About 5 to 10% of patients are with inherited amyotrophic lateral sclerosis. The offspring of a patient with amyotrophic lateral sclerosis will have a 50% chance of developing a similar condition. Disorganized immune response is also a cause for amyotrophic lateral sclerosis. The immune system may attack some of the cells of the body, possibly killing nerve cells. Chemical imbalance is another cause for amyotrophic lateral sclerosis, where the patients often have higher levels of glutamate secretion, a chemical messenger in the brain near the motor neurons. Higher levels of glutamate is known to be toxic to nerve cells. Mishandling of proteins can also cause amyotrophic lateral sclerosis, when body proteins are not processed appropriately by the nerve cells. Hence, abnormal proteins potentially accumulate and cause nerve cells to die. The symptoms of amyotrophic lateral sclerosis usually start appearing in late 50s or early 60s. However, symptoms can appear at other ages as well. Progression of the disease will vary between patients. Common symptoms include difficulty carrying out daily activities including walking, increased clumsiness, weakness in the feet, hands, legs, and ankles, cramping and twitching in the arms, shoulders, or tongue, difficulty maintaining good posture and holding the head up, uncontrolled outbursts of laughing or crying known as emotional lability, cognitive changes, slurring of speech and difficulty with voice projection, pain, fatigue, problems with saliva and mucus, and difficulty breathing and swallowing in the later stages. Early symptoms of the disease often include abnormal limb fatigue, clumsiness, slurred speech, and muscle cramps and twitches. Symptoms will spread all over the body as the disease advances. No single test can diagnose amyotrophic lateral sclerosis, so diagnosis is based on test results and symptoms to rule out other possible conditions with similar symptoms. The diagnosis of amyotrophic lateral sclerosis are made through electromyography to detect electrical energy in the muscles and nerve conduction studies to test the significance of the nerve signals. These diagnosis methods can help rule out peripheral nerve damage or peripheral neuropathy and muscle disease called myopathy. Certain medical conditions that produce similar symptoms to amyotrophic lateral sclerosis include Lyme disease, multiple sclerosis, HIV, West Nile virus, and the polio virus. Amyotrophic lateral sclerosis is confirmed in case there are symptoms in both the lower and upper motor neurons. Upper motor neuron symptoms include resistance to movement in the muscles and brisk reflexes and stiffness. Lower motor neuron symptoms include muscle atrophy, weakness, and twitching. Now look at extract 2, questions 37 to 42. You hear the doctor giving a lecture on tests used on biopsy and cytology specimens to diagnose cancer. You have 90 seconds to read questions 37 to 42. Usually, the grade and type of a cancer is clear when the cells are observed under a microscope after routine processing and staining. However, this is not always the case. At times, the pathologist requires to use other procedures also to diagnose the cancer. Histochemical stain tests use various chemical dyes that are attracted to certain substances in some types of cancer cells. For instance, the mucicarmine stain is attracted to mucus. Droplets of mucus inside a cell exposed to this stain will look pink-red under a microscope. This stain is useful if the cancer cell is suspected for an adenocarcinoma in a lung biopsy. Adenocarcinomas can produce mucus, so by detecting pink-red spots in lung cancer cells, pathologists will decide if the diagnosis is adenocarcinoma. Besides being helpful in sorting out different kinds of cancer tumors, other types of special stains are used in the lab to identify microorganisms, such as fungi and bacteria in tissues. This is significant because the cancer patients may develop infections as a side effect of treatment, or even due to the cancer itself. It is also essential in cancer diagnosis because some infectious diseases cause lumps to form that can be confused with a cancer tumor until histochemical stains prove that the patient has an infection and not cancer. Immunohistochemical stains or immunoperoxidase stains are another significant category of diagnosis. The basic principle of this procedure is that an immune protein called an antibody will attach itself to antigens, which are on or in the cell. Each type of antibody identifies and attaches to antigens that fit it exactly. To find out whether the antibodies have been attracted to the cells, chemicals are added that make the cells change color only if a certain antibody is present. Immunohistochemical stains are very useful in diagnosing certain types of cancers. For instance, a routine biopsy of a lymph node may contain cells similar to cancer. However, the pathologist may not be able to distinguish whether the cancer originated in the lymph node or elsewhere in the body and has spread to the lymph nodes. In case the cancer originated in the lymph node, the diagnosis would be lymphoma. Or else, if the cancer originated in another part and spread to the lymph node, it could be metastatic cancer. This distinction is very essential because treatment depends on the type of cancer. Often, flow cytometry is used to diagnose the cells from lymph nodes, bone marrow, and blood samples. It is very precise in diagnosing the exact type of lymphoma or leukemia. It also helps distinguish lymphoma from non-cancer diseases in the lymph nodes. Flow cytometry is also used to measure the amount of DNA in cancer cells called ploidy. Instead of using antibodies to diagnose protein antigens, cells are treated with special dyes that react with DNA. If the DNA amount is normal, then the cells are said to be diploid. If the DNA amount is abnormal, the cells are categorized as aneuploid. Aneuploid cancers of most organs tend to grow and spread faster than diploid ones. Another significant purpose of flow cytometry is to measure the S-phase fraction, which is the percentage of cells in the sample that are in a certain stage of cell division, called the synthesis or S phase. The more cells in the S phase, the faster the tissue is growing and the more aggressive the cancer will be. Like flow cytometry, image cytometry tests use dyes that react with DNA. However, instead of suspending the cells in a stream of liquid and analyzing them with a laser, this method uses a digital camera and a computer system to measure the amount of DNA in cells on a microscope slide. Image cytometry can also determine the ploidy of cancer cells, like flow cytometry. This is the end of Part C. You now have 2 minutes to check your answers.